are going to talk to you about developing interprofessional relationships, because really in exercise, when you're integrating exercise into a medically complex domain like cancer, there's really nothing more important. You can have all of the infrastructure, you can have all of the tools, but if you don't have good relationships with the professionals that work on the teams to manage these complex patients, you're going to struggle. You could have the best exercise program. So we really want to go through and provide some insight using the cancer care continuum as an example. So when we think about the cancer continuum across the lifespan, as you see it outlined here, we think about from really the lifespan, we think about preventing cancer and screening guidelines. And for some of our population, a large number, they will develop a cancer diagnosis. And through diagnosis, treatment, and then long-term follow-up for the remainder of the lifespan, those individuals look different, and they have different needs. So when we think about things like health, wellness, healthy behaviors, nutrition, those things span our lives, right? The lifespan of every individual. But when we run into individuals with or who have lived with or beyond cancer, they look different. So we're going to talk through this survivorship or the cancer care continuum, because as an individual is diagnosed, treated with, and moves beyond cancer, treatment side effects lead to impairments that can lead to disability. Not only do those side effects occur during treatment, but they can occur in the long term. So we talk about this term of cancer survivorship. And survivorship really starts at the point of diagnosis. This isn't someone who's done with treatment and is now going back to their life, because the truth of the matter is, for some individuals, they will have cancer and they will live with disease and they will live with temporizing treatment for the remainder of their lives. Some people go through treatment and they complete treatment and go back to their activities and their work and live cancer-free. So when we talk about survivorship, we're starting at the point of a cancer diagnosis, and I encourage you to think about exercise from that perspective. What are the elements of exercise, wellness, and health? As we move through this continuum, we need to be thinking about exercise, health behaviors, wellness, nutrition, etc., really throughout the continuum of care as well. So as I said, integrating exercise into cancer care delivery is about these interprofessional relationships that we want to talk about. Developing trust, mutual relationships, making sure that everyone is aware of your role and the value that you bring. And as I said, that's fantastic. Integrating our services into cancer care. However, the gatekeeper in cancer care, let's be honest, is the physician. And if we want to engage with physicians and we want to see these patients, they need an easy button. We cannot ask them to do a performance test. We cannot ask them, in some clinics it's even tough to get them to do physical activity as a vital sign. So we need to give them the tools to get patients to us, interfacing with us so that we can best engage to assess and examine and make an exercise prescription. So this talk will build upon the concept of how do we get patients who are in the medical care continuum, where medical care rises to the top of importance, maybe the health and wellness behaviors fall behind a bit. How do we equalize that? Using this beautiful approach that came out of the ACSM Cancer Exercise Guideline Roundtable. The concept that we want our physician colleagues to assess, advise patients in exercise, and referring them into the continuum of care that includes an exercise professional. So Dr. Schmitz is going to start us off first here. And we need to pull up her slides. Let me just minimize mine and go to, I don't know which ones are yours, Katie. There's an implement, there's an MA. Is yours, okay. Got it. So I'm going to have Dr. Schmitz now come up, and if I get her slides up, they're coming. It's all good. There we go. She's going to walk you through the cancer care continuum, active medical cancer treatment. Thank you.
There we go. All right. It is amazing to share the stage with the great Nicole Stout. She and I have been working together since, 1825 or something. Nice to be with you all today. Really, really nice to be at an in-person meeting. Thrilled to be with you and to share a little bit about what we are up to at the Penn State Cancer Institute. So as an overview of what I'm going to talk about today, I'm going to talk at the clinic level, how we embed screening and referral processes into clinical care at Penn State, and how we have gone about getting buy-in from clinicians. I'm going to talk about the One Group, just to sort of describe to you what the One Group is, but then talk about our website and the consultations and training that we do with patients. And then I'll finish with talking about workforce education and training and our amazing, amazing staff at Penn State. So the very first thing that needs to happen in trying to get clinicians to make referrals of their cancer patients to an exercise or rehabilitation program is to clarify for them who to refer. And our conversation with them really went something like this. What is the profile of the patient you would like us to refer to you? Our answer, they are breathing. We'll take it from there. So we want all of them. We want everybody to come our way. And it really honestly was a conversation. I'm not joking. That is not a joke. That was a conversation that actually happened at our cancer center. There's a whole lot else to say about interpersonal collaboration or interprofessional collaboration. We do triage our patients, and patients go back and forth between the One Group and the exercise team and the rehab team, so I'll talk about that a little bit more later. But we are really blessed at Penn State to have something called the CARE Center. CARE stands for Cancer Assistance and Resource Education. It was put together by the clinical psychologist who runs all of the psychosocial distress screening and care for patients at Penn State Cancer Institute. And they raised a considerable amount of money to build out an area within our Cancer Institute where if somebody needs specific help with psychosocial distress, with psychological care, they are sent to the Care Center for evaluation and treatment. And had to have the conversation with those guys as well. We went to sit down and talk to them and say, well, you know, we'd like you to refer people to us. If you have somebody come through your doors, then, you know, let them know that the One Group exists and refer those patients to us. And you had to actually sit down and figure out the logistics of how that happened. So it wasn't just a matter of, oh, hey, give us referrals. It was, give us referrals and here's how. Here's the email that you are going to send something to in order to tell us that Jane Doe is ready to work with an exercise professional in oncology. So we have a secure email at Penn State that can be used within our electronic medical system so that clinicians can send us information and tell us that there is somebody that they're interested in. One of the things that I do want to emphasize is that not every patient who is offered this referral says yes. A proportion of them say, why would I do that? So we still have an issue, even when we get strong referral base from our clinicians, we still have an issue with patients having a culture of cancer that says rest, rest, rest. So we still need to work on that some more, and more thoughts on that later. We also things have gone sort of, fallen into my lap at Penn State. The entire team, clinical care team, seems to have really gotten the message that we need to be referring people to the One Group. And there is a reason for it. I didn't actually put it on a slide, but I'll just share with you that the way that cancer care happens is dictated in part by standards that are set by an organization called the American College of Surgeons Commission on Cancer. If there is a standard that says everybody needs to stand on their head and spit nickels, then everybody needs to stand on their head and spit nickels. So it just simply has to happen. If it's part of the standards, it has to happen. So there is now a standard that says you have to be able to refer people to some kind of rehabilitation or exercise programming. And in order to be in compliance with that, the nursing staff who were in charge of making sure that that happened figured out that we had this thing called the One Group that could actually be helpful to them. So that is one of the ways that you get buy-in from clinicians. You answer a problem, you help them to solve a problem. So that nurse, Crystal Youngs, who is in charge of the nursing side of our cancer committee, figured out that it would be easier for the clinical care team to be able to reach the one group and refer patients to the one group if there was an easy button. And that easy button is that there is now within our electronic medical record, there is a place where they can click to say, I would like to refer this patient to the one group. And an automated email comes to that email address that I noted on a prior slide, and that alerts our 2 exercise oncology staff, both of them trained at St. Francis, right? Both of them really, really excellent at their jobs, and with about 3 clicks, the clinician is done with the referral, and we take it from there. So how do we get buy-in from these clinicians? Well, lots of research. We have been, I've been at Penn State now for 5 years, and at every possible turn, if I am going to be recruiting patients, I am asking for input from the clinicians that I'm working with, and getting their feedback and incorporating their feedback into the protocol that we are using, and where I can. And also, we add them to our papers. We include them in our research team, so that they don't end up feeling like, nobody wants to feel like they're being used, right? So the clinicians see these patients all day, every day. They have interesting and helpful information for you. Use it. That said, really, disease teams and clinicians are one trial negative learners, which means if you come in saying, well, I thought maybe that we could do some exercise. I'm not really sure what, but if you come in not unprofessionally, if you come in without being ready to say, I'm interested in talking to you about your early stage patients who are between when they get their chemotherapy and their radiation, we'd like to capture those people in order to help with their physical function, because I've noticed in your electronic medical record that the functional status levels of those patients based on ECOG scores is going up from the point when they are diagnosed to the point that they are done with their chemotherapy. If you walk in with that kind of data-based information and understand what these clinicians are seeing on a day-to-day basis, that is going to get their attention. So you have to be a bit of a mini oncologist. Sorry, but there it is. They will assume that you understand what they are up to. They will assume that you get that they are with their patients for 15 minutes apiece, and that that's all the time that they get with their patients, right? So they assume that you understand the flow of what's happening in their clinic. So go shadow somebody for a while if that's something that you need to do. You also need to be ready to start at the beginning, because everybody in this room has already drunk the Kool-Aid, and everybody here believes that exercise is useful for these patients. The clinicians are not there. In fact, you may run into some who are pointedly against the idea of their, we have one at Penn State who is pointedly against the idea of their patients being physically active. So you can't walk in with the assumption that they're going to say yes and that they want this program to happen. You want to walk in from the standpoint of saying, I'd like to have the opportunity to present to you some evidence that exercise could be good for your patients. It could be that in the conversation that you have with them that they say, I don't need that talk. I already know that exercise is good for these patients. Then you can skip on to the next stage. But finally, the other thing that we find is crucial, and in fact we have research evidence that this is the case. If you don't give the clinicians any feedback about what's happening with their patients when they're in your studies or doing your exercise program, then they feel ghosted. They need to know what you've done and whether what you've done has actually helped their patient. So let me describe the one group to you very briefly. There's a lot here that's about research, and it's not about particularly what we're talking about today, but I just wanted you to know it's kind of an opportunity to introduce this group to you all. This is the homepage for our website. There are 14 PhD or MD trained investigators that are a part of the one group, and a laundry list of staff, trainees, pre-docs, and postdocs as well. We are extremely well funded. We, between the 14 different investigators, have 6 investigator-initiated grants from the National Cancer Institute. They're called RO1s, and a number of other types of NIH funding as well. So you can see there's a lot of different types of funding there from foundations and institutional sources as well. In addition, a number of the trainees in the group have funding in order to do their research as well. So some of these are pre-docs, some are postdocs, and some are junior investigators. We are very productive. We write a lot of papers. The year that we have this for is actually last year, and we published 114 peer-reviewed publications across all of the 14 investigators and the trainees, and submitted 63 grants, and 36 of those were funded, which is a pretty good rate of funding. In the process of dealing with the COVID crisis, we recognized that we were unable to do our clinical practice, which is all of those referrals that I was talking about, and the practice of actually delivering exercise to cancer patients as they're going through their cancer treatment. And so we thought that we would develop something that would be virtual and that would provide a program that would step in where we can't see people in person. So we've had requests for collaboration and for use of these materials from 4 different health systems across the US so far. So we think the website has worked out pretty well. It's also, the group is also a shared resource. So there's space, we have command space at Penn State. There's staff whose time can be purchased. There's equipment that we own that can be borrowed for research and clinical purposes. And then we do a lot of managing, a lot of consulting, because I'm delighted to tell you that there have been some MDs, some clinicians in the Cancer Center who've come back to us and said, you know, I actually think exercise might be really good for these high-PEC patients. I'd like to do something on this, but I don't know the first thing about how to prescribe exercise. Can you help me? So it's been great, and that to me feels like honest-to-God buy-in. So the One Group website has a number of different areas. One of them is the practice area, and you can see that there is an easy button in the middle top row that basically says, request a consultation now. We do occasionally get consultation requests from outside of Penn State. We take them to the extent that we can afford the time. We take them. There's a section called Inspiration. So for those of you that have never seen it, there's an amazing, amazing documentary out there called Phil's Camino, and it's about a stage 4 colon cancer patient who gets permission from his clinicians to stop treatment long enough to go to Spain and walk the Camino. And it's like a 500-mile walk. I don't think he did the whole thing, but anyway, it's an amazing, amazing journey. And the filmmakers have allowed us to have the film and a link to the film for free on the One Group website. So go check that out. Just grab some tissues before you do. And then, of course, we have a lot of research, and there's training opportunities within our group as well. We developed 68 different exercise videos, and we have something called the WOW, or Workout of the Week. So we take combinations of videos and say, do 2 of this exercise, 2 of this exercise, and 3 of this, and call it a day. So we try to keep that fresh. And then there are 30 different handouts that are in the areas of exercise, nutrition, managing side effects, and improving mental health. So the consultations and training. So obviously it's not just a matter of giving people the website, send people to the website and they're done. That is sort of the first pass. If somebody can't come to see us, is unwilling to come see us, or lives really far away or in a rural setting, that's an option for them. But once we receive the referral, we make a call to the patient to get things started, and we do a triage survey. And if appropriate, if they say yes to something on the triage survey, then we make a referral to the physical medicine and rehabilitation cancer physiatrist, if appropriate. We then, if it is appropriate for them to be doing exercise, and this is not an either or, by the way. So there are times when we refer somebody to PM&R and we see them in the exercise medicine unit and we get them going. Could be that they're dealing with one thing with PM&R and another thing with us. For their training, we really personalize what it is that we do for the patient according to what we see. So we have people who come to us who are regular runners and, used to doing weight training on their own. And those folks come to us because they don't know, based on the culture of cancer, whether it's safe for them to continue exercising during their treatment, right? So those folks really want to hear from us whether they should back off a little bit and exactly how much they should back off. And we do a lot of consultation with those folks, but we don't pull them in for one-on-one personal training very often. And then, of course, we get the 82-year-old woman who's never done any formal exercise in her entire life and, who would really benefit from increasing her strength and mobility. And, so we pull her in and we do an evaluation, and then we see her every time she comes in and give her a home program as well. So it really varies according to the function of the person when they come to us and their exercise IQ, if you will, walking in the door. So in terms of like, who is this? Who's doing this? My secret sauce is St. Francis. I am so lucky that I work in a place that has access to students that have been trained so beautifully, so lovingly by the master's program in cancer care at St. Francis University. I'm showing here Jared Heitzenrotter and Beth Kansky, who are both grads of that program and are full-time staff that work with the one group and form the basis of all of the exercise consultations that I've just been talking about. So what do they need to know? What are the knowledge, skills, and abilities that they need to know? Well, that's a whole talk in and of itself, but the high points, if I might, include master's level knowledge, of course, of exercise physiology principles. But then knowledge of how cancer is screened, diagnosed, treated, and how side effects are managed. So understanding if somebody comes into you and says that they are having peripheral neuropathy or they're having pain, understanding what it is that the physician is likely to do, what they're likely to prescribe, and what that will mean for your exercise prescription. If they are going to be taking high doses of gabapentin, does that change anything for you? Okay? So you need skill with review of medical records because nobody in the cancer care team is going to take the time to explain to you what's happening with your patient. You need to be able to read through the medical record and understand what the medical record is saying. And that is not something you're going to get in a master's program for the most part. That is experience. That is sitting with medical records and staring at them and printing pages from it and going to somebody and saying, what does that mean? Right? So that's on-the-job training. The ability to balance the physiologic needs and goals of an exercise training program with the human needs of the cancer patient. So could well be that the person you're facing is so freaked out by their diagnosis that really what you need to do is deal with their anxiety first before you deal with their cachexia or their sarcopenia. Okay, so it may be that the human needs, the psychological needs come before the physiologic. And then finally, as I mentioned before, the cancer clinical care team is often a one-trial negative learning group. And what I mean by that is if you walk in and you say, I really need to see this patient, and it is not the appropriate time for you to see that patient, and you are at all insistent, if you do not know your place in the pecking order of clinical care, which is the bottom, then, and you don't behave in that way with a lot of deference for the clinicians that you're dealing with, then I was very blessed to have, I had one medical oncologist who gave me a warning about one staff person, and I talked to the staff person, and the medical oncologist gave me a second warning. I was amazed. She didn't shut me down. She didn't stop me from seeing her patients. She gave me a second warning, but that staff person never went to the clinic again. So we only get access to these patients if the clinicians tell us that we can have access to these patients. If we do anything that is against or in the way of them doing their jobs of trying to cure that person's cancer, treat that person's cancer, we're shut down. So you need to recognize your place. So in terms of interprofessional collaboration, we actually had an unusual situation grow up within the situation of the Penn State Cancer Institute, because I started at Penn State 5 years ago, and there was no cancer rehabilitation that existed when I arrived there. And just recently, Dr. Sarah Lay has been hired, and she is a physical medicine rehabilitation physician with specialty in cancer. And everywhere she goes, when she goes to say, this is what I do, this is what I can do for your patients, everybody says to them, oh, you should send them to Kathryn Schmitz. Oh, you should send them to the one group. So we are actually having to retrofit and back up and figure out how to work well with Dr. Lay. And so we've developed a screening survey with her, and we make referrals. We have already made referrals to Dr. Lay, and she makes referrals to the one group from PM&R when appropriate. So just as a larger, just so that you understand what I've just said in larger context, there is an initiative of the American College of Sports Medicine that is an international multidisciplinary initiative called Moving Through Cancer. And the initial task force pictured here came together right here in Camp Hill, Pennsylvania, for a retreat in order to understand what we would need to do if we were going to make exercise standard of care by 2029. We came up with an agenda, and we have published our agenda-setting paper in the journal Cancer in 2021, so go take a look for that. And I'm not going to spend a whole lot of time on this. I just want you all to know that this exists out there. But there are 5 different agenda areas that the workforce, or that the task force is working on now, including workforce enhancement, program development, research and evaluation, stakeholder awareness, empowerment, engagement, and policy funding and sustainability. The current task force is international and multidisciplinary, and includes a medical oncologist, an oncology nurse, a physical therapist, 2 exercise physiologists, policy wonk, oncology nurse, did I say that? PM&R doc, and the head of nutrition and physical activity programming at the American Cancer Society. I just also want to give a short little plug for the fact that I have written a popular press book called Moving Through Cancer that is now available not just for pre-sale, I need to update that slide, for sale. And the idea behind this book was that, we published those lovely papers about exercise and cancer from the ACSM Roundtable, but that information means absolutely nothing to the average cancer patient. All of that information needed to be translated to the lay audience, and that's what this book is. So I would hope that you would commend it to patients that you come in contact with. In summary, there are a multitude of puzzles that we're going to need to solve in making exercise standard of care, and I'll look forward to hearing what your role will be in this story. Thank you.
So Dr. Schmitz has given you a phenomenal overview of a program that is of a magnitude that many of us aspire to. Where's my West Virginia peeps again? This is our goal, right? This is where we want to go. And we want to develop an infrastructure to do that. What I want to move into now is having you start to think about, not only is there a need, desperate need for individuals to exercise during cancer treatment, and being embedded into the Cancer Institute is the most ideal way to get that engagement, bar none. But there's this time period when an individual transitions out of active medical treatment, and this is a recognized gap in care across supportive care services, not just with regard to exercise. In fact, gosh, it's been almost 20 years ago that the Institute of Medicine issued a report called Lost in Transition. And what they talked about was the fact that when people finish active cancer treatment and they transition out of treatment back into life, it's a really difficult time for them. Follow-up care, managing late effects of their disease treatment, it's a real challenge, and we don't do a good job of being the medical providers that help to support individuals in that transition. So how do we, as exercise and rehab professionals, engage to help with that transition and to help to promote and engage in the exercise and activity through that transition, so that we can build the behaviors either back into the individual's lifestyle, or if they're coming out of a program like Dr. Schmitz, how do we help to maintain, right? If we're the community-based provider receiving that patient, how do we help? So when I think about the cancer care continuum that we've been discussing from diagnosis really through the remainder of the individual's lifespan, I also think about the functional continuum that goes alongside of that. From the very point of a cancer diagnosis, risk is introduced. And as an individual proceeds through the multitude and different treatment interventions, the side effects accumulate over time and can lead to a disability burden. So if we're not engaging with exercise during that continuum, the risk is when they transition out of treatment and into this survivorship phase or the remainder of their life out of active treatment, they could be in a very disabled state. Now, the other thing we have to remember is that function is not a static phenomenon. It's not a static thing. Function can be influenced by exercise and activity, nutrition, health behaviors. So something that has emerged is this concept of survivorship care. Years ago, we developed survivorship care plans, we in the cancer community. We talked about the need for a care plan to give to the patient as they finish treatment and transition away from the medical establishment. So the care plan outlines what type of treatment they had, it talks about side effects, and then we hand them off to their primary care physician. So what we've learned in the last decade is that that has gone terribly. We have not done a good job of adequately capturing what's meaningful in treatment. Survivorship care plans became a checkbox because they were an accreditation standard from the Commission on Cancer. So it became this checkbox. We did the care plan, we did the care plan, we did the care plan. Patient got a piece of paper and the patient said, "What the heck does this mean?" Take that to your primary care physician. Okay, and the primary care physician got the care plan and said, "What the heck does this mean? What am I supposed to do?" So what we've seen now is a movement towards the concept of survivorship programs from the point of diagnosis, comprehensive programs. This is the new standard from the Commission on Cancer. So the survivorship program team is an interdisciplinary comprehensive team. Again, a great place for you to have a role in helping to develop not only the plan of care through treatment, as you saw in Dr. Schmitz's program, but a critical role for you to play as that handoff occurs out into a community-based setting. So our survivorship care program is working right now to integrate prospective functional needs assessment throughout that continuum of care so that when a patient gets to the end of treatment, it isn't the end of the supportive care service awareness. We're ready to make a handoff because we've engaged this interdisciplinary team throughout the continuum. We don't just get to the end of treatment and say, well, you're cachectic, you have neuropathy, you've lost a lot of memory and cognitive function. We need to rehabilitate you now or fix these things. We're monitoring those throughout the duration of treatment. So we use this interval repeated surveillance. Patients are aware of the support services. They're educated throughout about these health and wellness behaviors. So that when we move into this post-treatment phase and the ongoing surveillance now moves to primary care, there's a bit more of a bridge. There's more of a bridge. The patient is better educated about the services that they need or that they've had. They move out into the community knowing that they have a provider like an exercise physiologist or a rehab professional walking next to them with that information and helping to connect them to local supportive care services, right? So in West Virginia, we have a phenomenal cancer institute in Morgantown. We have a phenomenal cancer institute in Berkeley. We have a phenomenal cancer institute in Wheeling. And then there's the rest of the state. And that's really where people come from. So as I go to hand off this transition, I can't expect them to continue to come back to me in Morgantown, drive 2 hours to come in 3 times a week for your exercise program. So the community linkages become critical at this point, and this is where you building capacity in the communities is so critical, such an important role. So identifying local supportive care services. Where are the exercise facilities? Where are the community wellness centers? County-based services, perhaps. Is there a YMCA in your area? Could you build relationships to develop the workforce, knowledge, skills, and capabilities in those community-based centers and resources? What about the primary care providers? Is a primary care provider going to say, whoa, this person just finished cancer treatment, they had a bone marrow transplant, they should not be exercising? First of all, that's wrong. I'm not going to say that to them, but we're going to have an informed conversation about how to change their attitude and perspective. So there's a lot of work to be done right now moving out into the community level. Community-based cancer survivorship is an emerging area that people are starting to think about because we've really just tried to promote survivorship care from the Cancer Center, Cancer Institute-centric approach. It's not good enough. So we need to reach out into the communities. So when we think about now, this program expands and extends. So where are my community-based exercise programs? How do I facilitate their knowledge, skills, and abilities to manage individuals with cancer, to understand the late effects and understand the sequelae? Well, if you're out in one of those community-based cancer exercise programs, you know, the old saying that people like to say is, no man is an island. Well, I say, unless they choose to be. You can choose to be an island. You can choose to be out there in your exercise facility, in the gym, just doing a one-off program. Or you can choose to approach a pathway that establishes comprehensive care for medically complex patients like those who have cancer. But in order to do that, the communication strategies with the healthcare providers become absolutely critical. Sometimes that's a reach back to the cancer center, but most of the time, that's going to be the outreach in your local community. What type of services exist in your community that you can help to augment, to support those cancer survivors? Establish your program with credibility, right? Cancer rehabilitation, cancer exercise is a hot emerging thing right now. It's easy to hang out a placard and say, oh yeah, we do exercise for cancer patients. Why would we not? We do exercise for anybody. Having staff that are trained methodically in the premise of cancer, the side effects, the treatments, having them understand the late effects. How do you gauge vital sign changes for individuals when you're exercising with them with an exercise prescription? Because their vital sign response is going to be different because of the chemotherapy that they have or are having. They may be tachycardic at baseline. You need to know that. You need to know that that's normal. What is normal for the cancer population? So establishing your program with credibility, having staff trained, having programs that really truly are dedicated to individuals with cancer, bringing them together. Not only is it great for them to exercise for health and wellness purposes, the support community that you can create among a group of cancer survivors, giving them an outlet, license to exercise and to feel good, bringing them together in a social supportive environment is phenomenal. Show your value to those medical providers. I think Dr. Schmitz's comment was apropos. Know where you are, and unfortunately, I'm a physical therapist. We're right there with you, down on the bottom of the rung when it comes to the medical establishment. Now, in the community, you're thinking about the primary care providers and their perspective, thinking about those PCPs. Maybe it's nurse practitioners in your community care, primary care facilities. So how do you show your value to them? And as Dr. Schmitz said, it isn't just saying, hey, we can do some exercise over here for people with cancer. Let me tell you what we can do to help you better monitor your patients for the late effects of cancer treatments. We will reassess them at determined intervals. We will use validated measures of performance. We will identify the early emerging impairments that are known to be associated with late effects. Radiation therapy can do damage to the heart that may not turn up for 5-10 years after the completion of treatment. Many cancer treatments are the gift that keep on giving. And an identified issue with a survivorship population is that we must monitor them for the late effects of disease treatment. Much of that is physical, the physical side effects. You can show value through your program by monitoring, reassessing, and being the person who can contribute to the early identification of those late effects. So providing those regular reassessment time points and providing a cohesive report, not just back to the provider, but to the patient. You may not have access to the medical oncologist. You may not have easy access to the primary care physician. But if your patient's on board and understands the repeated tests that you're doing and has a consistent report, they can take those with them back to their primary care provider. Guess what? My strength has improved so much. I'm now physically able to get on a bike and go out on the road, but guess what? I also now have the confidence to do it. that sends the most critical message to the primary care provider. Hey, this person knows what they're doing, and they're doing it well, and they're benefiting the patient. You're going to win every time. Also, report your findings in context. If you send, VO2 test results, 1-rep max results to a physician, I'm sorry, they don't care. It's important to you and I to gauge and measure change over time and progress of our patient. But think about how that contributes to the individual's function and quality of life. So being able to show, I've improved their strength, I've improved their mobility, their balance is better, and here's how that is contributing to their quality of life and to their function. They're able to go to work and get through their full day now without having to take a break in the afternoon because they're so fatigued. Their cognition has improved, and they're able to solve high-level problems that they weren't able to do before. Those are the meaningful things that my patient's pain is significantly less because of the intervention. Their sleep patterns and habits have improved, and they see a noticeable difference. So report your findings in context to what matters to those late effects and to the patient and the provider. Be flexible with technology. Oh my boy, we are in the technology. We had technology sort of just thrown on us, right? Over the last year and a half, we've been forced, and our patients have been forced. And it's been a challenge. Being in a rural area, it gets me so frustrated when people sort of give a hand wave to, oh, the technology is just going to solve all of the problems of rural health. Have you driven through the hollers in West Virginia and tried to stay on your cell phone? A mile off of Interstate 79, I don't have cell phone service in many areas of West Virginia. So to think that broadband, that electronic communications are going to be available and solve the issues, maybe, maybe not. So be flexible with how you use technology. This is a framework that has been published around survivorship care. Now, it's very small in print, but I'm going to highlight a couple of areas here to show you where you add value. So this was published by a really important group of smart people at the National Cancer Institute who said, we need a framework focused on primary care providers so that they know what the needs are of cancer patients as they move beyond active medical treatment and out into their communities. This framework for survivorship needs to address many different aspects of late effects, cognitive long-term effects, return to work. So all of these really important things are embedded into this framework. So how does this apply to you? How do you show value? Our primary care providers are looking at this and they're struggling to say, how do I do these things? These are important. This is already driving new standards around survivorship care. How do I do this in practice? Here's your value add. Part of this, one domain that's identified in this framework is surveillance and management of physical effects. Those late effects that we talked about. Somebody has neurotoxic chemotherapy. They develop sensory neuropathy. They develop proprioceptive neuropathy. 6 months later, they're tripping and they're stumbling because they don't have good sensation in their feet. They don't have good proprioception. They walk around outside, now they start to fall. A year and a half later, 2 years later, they're falling and they're having injurious falls. So recognizing the tie-in between those issues, the exercise interventions that can help to mitigate or prevent those sequelae, and how that contributes to these late effects. This is an important tie-in for us to be able to make. My exercise prescription and interventions can help to mitigate the consequences of many side effects and late effects. In some instances, we can help to prevent some of these side effects. If we can demonstrate effectiveness in exercise at preventing falls, oh, that's huge in the cancer population. Patients who've had neurotoxic chemo agents fall at about 30 to 40% higher risk of 30-40% higher percent of frequency of falls than other individuals age-matched cohort in the population. Having had cancer is a fall risk factor. So assessing, tailoring our assessments to understand the physical effects. The other really important part of this, which obviously falls into our domain, is health promotion and disease prevention. We need to show our value so that these things have been regarded as kind of, well, nice to have. Our physician colleagues say our patients are going to experience pain. They're going to just be fatigued. That's just the way they're going to come through cancer treatment. And quite frankly, With the evidence that we have today, that answer is not good enough. It's not good enough to just say you've survived cancer treatment. You should be happy to be alive and just deal with these side effects of fatigue and muscle wasting and balance deficits. It's not good enough. So the health promotion and prevention, smoking cessation, weight management, facilitating behavior change, these are the things that we do really well. We know the strategies to help individuals embed new behaviors in exercise, promote and motivate exercise behaviors and nutrition behaviors in these folks. So we stand to play a very important role in health promotion and helping to support this framework. These are the messages to take to your oncology colleagues, but also mostly if you're in that community setting, to your primary care colleagues, because they're going to look at you and they're going to say, oh my goodness, thank God, somebody who knows what to do with an individual who's survived cancer, who comes into my office and has this litany of problems, and what am I supposed to do to help them live better? They should press the easy button and refer them to you. So there's so much evidence, right? The evidence is tremendous. And why are we still so disconnected? So some of the initiatives that Dr. Schmitz spoke about, Moving Through Cancer Task Force, the textbook that she wrote, several of the papers that have come out after the guidelines were published. We published guidelines, great, pat us on the back, but how do we use them, right? How do we solve this disconnect? I think we need to talk about convergent strategies in demonstrating this value. Our medical oncologists, our primary care providers, they're worried about the patient having a recurrence of disease, surviving their disease, having devastating side effects from disease treatment. So what do we bring that changes that? If we can show our value in reducing toxicity from disease treatment, improving survival for these patients, improving quality of life as they survive, endpoints like returning to work, less utilization of medication, drugs, less utilization of tests and imaging and scans. That's the value that we can show through exercise interventions, through our engagement from the community level. So I would encourage you to think about your value proposition in that community-based setting. Your primary care providers, I mean, we need an easy button for oncologists, but we need a super duper easy button for our primary care providers. They are overworked right now. They are to the max with dealing with patient volume, but also patient complaints and issues. Many of them are not well trained to manage individuals after cancer treatment. They just don't know. They don't know what the guidelines are. They're not sure what to do. You can really step in and be a nice safety net to help to support them. Go to them with this value proposition. I like to tell my primary care providers, if you have problems, your patients with cancer have problems, just send them to us. We can help to alleviate the problems. We're your problem solvers. If it's fatigue, if it's sleep, if it's anxiety, there's an exercise evidence base to support our role in all of those impairments. So let us work with them. Let's see where we can get that individual to solve your problem. And your primary care provider, like the light goes on, okay, good, I see value in you. So think about the value proposition. I'm going to hand off now to Ms. DeJarnett, and she is going to express to you and share with you some absolutely amazing work that they're actually doing in the community to take this really to the next level.
So, like I said, I'm with the Berkeley and Jefferson Medical Center, which is underneath WVU Medicine, which now we have like, I don't know how many hospitals in our system now, where they're buying the whole state's hospitals. They just put on 2 more in the last couple weeks. So, let's see. All right. So you probably heard, I know earlier this morning there was a talk on COVID and what COVID had taught us, and I just kind of wanted to point this out as we obviously have learned how important our health is and prevention is for, prevention of, catching or getting adverse effects of COVID. The other things we kind of we learned though was the health disparities have really become heightened, and the social determinants of health, which I'll talk about in a minute, and that local matters. You couldn't go anywhere, you couldn't do anything, so what did you have locally that you had access to? Our parks have gotten way more use in the last couple of years than they have in a long time. Obviously bike sales, I don't think you could buy a bike for a while, so people were looking at what they could do locally. and I don't know if anybody heard social determinants of health. It's kind of a buzzword that's out recently, so that's very important. And the biggest thing is to understand that it's not all just my personal choices that affect my health. You know, it's your environment, the culture of your community, what you have access to. So it's not just all about, oh, I ate an extra piece of cheesecake or had another beer or whatever it is. It's not, or I'm not exercising. There's other factors that play into that. Have you all heard of adverse childhood experiences, or ACEs? Okay, and if you have not heard about that, I would say look that up, because that's super important. It's a study that was done in the early 2000s, actually at Kaiser Permanente from Southern California. There was a doctor who had an obesity clinic, and he couldn't figure out why, you know, people did really well the first year, lost all this weight, and then in the second year gained the weight back, and you know, what's going on? And he did questionnaires and came back to the fact of what happened in children's lives with those people as children. You know, it's things like parents might have been divorced, there might have been abuse at home, there might have been an incarceration. There's like a 10 question questionnaire, which seems super simple to boil it down to that, but that affects health throughout life, and it changes you. That toxic stress that you're under as a child can affect you for the rest of your life, and affect you physiologically, and affect your health. So we have to look at all those kind of factors for people. That's my problem here. So the other thing to look at in people's health is it's the health of your community too, which then affects your local economy. So the healthier our people are, the healthier your workforce is, the healthier your community is. You know, all of these things play a factor in health and in economy, in your local economy. So one thing that hospitals need to do is they need to do a community health needs assessment every 3 years, and it's an IRS requirement to keep your nonprofit status, and you have to show that you're actually doing something with that community health needs assessment. So we did ours right before the pandemic, actually, in I guess 2019 in the fall is when we kind of started it, put a questionnaire out there. Now this is not like any kind of randomized controlled study. It's basically throw the survey out, try to get as many people to answer it as possible. We did really well this year and got 3,500 people to answer it. And I will say, you know, it may be skewed to one type of demographic, but because we had so many, we could pull out groups, seniors, low income, you know, all that kind of stuff, men, women. But I will say, looking at all the groups individually, they pretty much came up with the same priority areas and the same issues related to health. So as you can guess, this is a word cloud, and we are West Virginia, so you know the biggest things are addiction, drug use, obesity. You know. So looking at the top priorities, by far drug use and abuse is one of our highest. Obesity is next. This is what people felt like the health problems were in the community. So those are kind of the top 10 issues. I thought this was interesting because it's the top 10 reasons, or the top reasons for not receiving preventive care. So why aren't people going out and seeking preventive care? And the cost, they only go when they're sick or when it's needed. They have a lack of health insurance, lack of the doctors maybe available, and lack of time. The other way to look at this is the barriers to health. So why aren't they healthy? And it could be that they have existing problems, they didn't have the time, the weight, it's their choice, and age. And the interesting thing about this, if you look at those social determinants of health, you know, people are thinking, their perception is it's all about them, it's all their problem, but it's not. They need to know that there are other factors in there that are kind of working against them or working with them. This was just for people over 65. I thought it was interesting. Who would they turn to for information on health issues? So by far the top is the doctors, and then we Google things, which doctors absolutely love probably. And then your family, your friends, and your personal knowledge, and then that last one is actually a clinic in our area. So the hospital looked at what are the priority areas, and these are the areas that we decided were the priority areas for 3 years that we'll be doing our implementation plan based on that community health needs assessment. For the purposes of this, I'm just going to talk about the women's health screening because that involves kind of the cancer part of it. And we did get a grant from Mountains of Hope, which is our statewide cancer coalition. we created this Women's Health Initiative Network. Of course, this was pre-COVID when we thought we could do this, and our main focus was going to be a big screening event. We get women to come in, we do PAPs, HPV, discounted mammograms. We wanted to do the whole 9 yards, but of course we couldn't, so we kind of switched it up a little bit, although we do offer on a regular basis in May and October discounted mammograms. Women can come in, pay cash, $60, get a mammogram. A lot of insurance now pays mammograms, but some don't. And then we set up with the chamber, they have a women's network group already, so we have the Women's Health Series with that chamber group, and this is done by Zoom. So we were able to pivot and do everything that we might have done in person before, we could do by Zoom. So we covered a lot of different health topics. Each month was a health topic. Like I said, we canceled that screening. We have done the Walk With Ease program for years, but we kind of put this under there because we were looking at prevention and early detection was the two focus areas of this grant. And then we gave out the Good and Cheap cookbook, which is for people who are, it was developed for people on SNAP, which is the food stamps, $4 a day cookbook, basically. And then we have Med Chefs, which is a program from WVU. They actually, the med students that go through WVU learn cooking and learn nutrition. The two docs that are sitting there outside the tent have a culinary medicine certification from Tulane, and they do, as part of the regular curriculum for the med students, we have 3rd and 4th year students out in our area. They have cooking classes, and then they will go out in the community and do cooking demos. So we did those at our community gardens for this program. So these are just the flyers. We had the Women's Health. We actually tried to do a little thing on Facebook where we put like little 1-minute videos every day for a week to see how many people would watch. You got a lot of views, but you don't know if they watch, so we kind of tied an incentive to it. Not that many people actually participated that way, but the messages were supposed to be get your testing done, physical activity, nutrition, that kind of stuff. And then we had a special night at the farmer's market, and then that other stuff, and then this is the Walk With Ease program, which is actually an arthritis foundation program. It's good for anybody, but it's meant to be for people with arthritis. Our discounted mammograms. So the other thing I wanted to talk about was we actually have a group for Berkeley County called Healthy Berkeley. As you know, well, you may not know, but you probably have heard it in the news, West Virginia. I don't know how many West Virginians are here, but West Virginia always comes up with the worst on the list or the number one of the worst things on the list. So we have a lot of health issues. So the state Bureau of Public Health Division of Health Promotion and Chronic Disease has come up with this program called Healthy People, Healthy Places. And it just sets benchmarks related to fruit and vegetable consumption, water consumption, physical activity, and tobacco policies in your community. So your community, and it can be a city, it can be a county, it could be an area, you know, whatever wants to apply for this. The nice thing about it is it actually helps you evaluate your community and see what programs and services you have, what policies you have in place, what's available in your community that's healthy. So, you know, the end goal is to affect the change of West Virginia's health outcomes. For us, we found it beneficial because it's like, okay, where are we lacking and what areas do we need to create programs? So we, like I said, we have a group called Healthy Berkeley, started back in the early 2000s. We used to be called City Hospital before we were Berkeley Medical Center. So that's been around for a while, but we kind of revamped it in 2014, got some grants. We've had several just small grants, not huge. And then we actually applied as the city of Martinsburg in 2020, and then as the county 2021, and we've received the gold award both times that we've applied. So our committee, it's basically a collaborative committee of all people from the community, all walks. It's got the schools, it's got the health department, it's got, you know, library. We've got everybody. We've got citizens, people with private companies, all involved. Anybody that wants to be included is included. So looking at the different benchmarks for fruit, vegetable, water consumption, everything falls under policy, environment, and community clinical linkages, which I think is an important thing to look at for what we're talking about today. But, you know, just looking at our schools, we have wellness policies for our schools. We actually have a new dietitian in our county that's going to be revising the menus. Our county is about 100,000 people. We have about 17,000 in the city of Martinsburg, which is the largest city in the county. So I don't know how that compares to where you guys live, but we're not a huge community. So they restrict the sugar-sweetened beverages in the schools. You know, the vending machines are shut down during the hours when the school is open. And they try to policy healthy food and celebrations, but I've had kids in school and I know what goes on. They have a policy, but whether the teacher in that individual classroom follows it is different, or the parents. And then we have a community garden, which I'll show more pictures of. And then our hospital is considered a baby-friendly hospital. We have that certification because we promote breastfeeding. And then we have a farmer's market which accepts the SNAP, and there's a way for people to double their SNAP dollars and actually even stretch them and triple or quadruple them. So they give them extra money. You know, if they swipe $10 off their card, then they might get another 10 for fruits and vegetables, and then there's ways to even get up to $30 more. So. As far as the environment goes, we have a lot of schools, and this is something that's not unique to our community, so these are the kind of things you can look at in your community. A lot of schools have gardens. There's a lot of community gardens out there. We have some different fruit and vegetable consumption initiatives. We did a thing with the Boys and Girls Club. We had actually received a monetary award for this Healthy People, Healthy Places, which they normally wouldn't have done, but they couldn't travel because of COVID, which was a good benefit for us. But what we did was purchased fruits and vegetables because the Boys and Girls Club is giving out 5 dinners a week for kids and 5 snacks. And so we used that funding to add a serving of fruits and vegetables for them for the week. And sometimes it was enough to be able to feed the whole family. So again, we have the community garden. The purpose of the community garden is to have a place for residents to grow if they don't have the space where they live. But also we had a high tunnel where we grew and we would donate to different places. And then we have, our clinics have Farm to You, and I'll show you some slides on that. Another thing just to assess in your community is looking at your convenience stores, and most all of them have some kind of fruit or vegetable and water to purchase. CCAP is one of our food pantries. We started a nutrition initiative with them, and we do kind of this healthy challenge over the holidays with WVU Extension, so it's another one of our partners where we help people challenge them to track their activity and their water consumption over the holidays to try to keep them healthy. So it used to would be a way in, way out program, and now because of COVID, don't want to have anybody in person, so we found a way to do it without actually having people together, but they can actually use just an app to do that. And then again, at our farmer's market. These are some pictures from the community garden, just showing that space there. And then this is the part of the nutrition program at a food pantry. In the food boxes that people pick up, we have created a handout, and this one was for the holidays. This one talks about leftovers, talks about managing stress, I guess, and has some recipes. So let's see. This another thing is so this is the community clinical linkages of what we do with the fruit and vegetable and water consumption. So we have some evidence-based programs in the community that you can refer people to. Like I said, the clinic has this Farm to You program. A lot of work sites in the area have wellness programs, and then we have some faith-based wellness programs. The bottom 2 pictures there, we actually were able to do little farmers market in the schools this year with some funding from the Department of Ag and United Way. So a lot of schools had, because they didn't have in-person learning during the year, they had summer school that kids could come to. And then, so all the 5 intermediate schools, which was going to be, at the time, K through 5 this summer, that's where all those kids were. We did these little mini farmers markets. This is the clinic. This is the Center for Diabetes and Metabolic Health, but we do this at 2 or 3 clinics within the WVU Medicine system in the East, where actually patients can come once or twice a month and actually get fruits and vegetables for free, and they give them recipes and that kind of stuff. So, and those are from local farmers also. So looking at the physical activity benchmarks, first looking at policy, what are the policies of your county, your city, what's in writing about new developments that are put in? Do they have to have sidewalks? Do they have to have green space? And I was at a Parks and Rec meeting the other day, and sometimes the green space is where the water runoff is supposed to go. So technically it's not really a green space that can be used, but so needing to have regulations on that. What kind of trails are locally, what's in your plan about connectivity and walking paths and that type of thing. Looking at your environment, these are the benchmarks that they set, what do you have available? We had a nice park, this poorhouse, was getting a lot of use, but we never had a map. People would actually get lost out there and call and say, you know, we don't know where we are. So there's like 5 miles of trails out there, so we got some funding from a grant to make a map and have way signs for them. The other picture there is at the schools, just 5 local schools within the city area. We put up signs that basically say it's open to the public, you can use the walking trail, and that actually got more views on Facebook than most anything else we've done, just to put that out there. And it's really just a sign saying you're welcome to come and use this, where that wasn't there before. So this is our newest project. We put in a trail through a grant in a park that basically just has tennis courts, and it leads up to where softball and baseball fields are for the high school and the little league kind of thing. But it's a born learning trail, which is an interactive trail that parents, grandparents can do with kids. So it's not like super physical. It could be like tell a story, look for something soft, you know, what do you see, what do you hear, that kind of stuff. We actually put in some benches, though, in these other signs. If you can see, the bottom one says look, listen, and feel, and that is just kind of a mindfulness. Sit down and take in the surroundings. The other one actually has pictures of exercises you can do on a bench. So instead of spending a lot of money to put in exercise equipment at a park, you can do a lot of exercises just on a bench. So that's just suggestions for people to do. So also looking at, this is the community clinical side of it, looking at setting up prescription programs within physicians' offices to prescribe exercise for patients. We also work with West Virginia Health Connection, which is through Office of Public Health at WVU. It's a website that is got all kinds of the programs. They're trying to capture everything in the state for ways to refer in and out. People can go there for, you know, any program they're looking for that's going on in the state, like the Walk with Ease, like self-management programs, that kind of stuff. But we've also put in a trail inventory of all the trails in the county. So if people want to know where can I go walk, they can go right there to see. Let's see, kind of covered most of those other things. And then the last part of the Healthy People, Healthy Places is looking at tobacco policy and vaping. And not all counties, I'm not sure how it is in other states, but each county sets their own ordinances. And in West Virginia, not all counties are clean air, comprehensive clean air plans. We are in Berkeley County. You go to the next county over, Jefferson, they have a big casino. They're not going to go clean air for comprehensive clean air. And then our Parks and Rec also made their own policy about tobacco and vaping within the parks. And this covers fairs, festivals, any kind of community events that are going on. They should all be smoke-free. So just examples of some of the programs we had. We do wellness screenings. We have the self-management programs. So this leads me into the last thing I wanted to talk about was a new grant that we got, and this is where the work with Nicole is coming in, and we're looking at putting a cancer and exercise program within our Cancer Institute, and we want to train physical therapists and physical therapy assistants, the patient navigators, which were within the Cancer Institute, and then personal trainers. Now again, I don't have the wellness center, but we partner with now a local fitness center, so we're looking at working with them. So we're going outside of ourselves to try to find where we can partner with somebody. So we'll have a policy in place. How are we going to assess the patient to determine what their needs are, and then refer them? So, and we'll have these options, whether it would be appropriate they need to go to physical therapy, maybe they just want to do some at-home exercise, and we'll have like some bands or just small equipment that we can go. And I'm thinking actually I should get Katie's book, Cancer on the Move, and give that to each of the patients to have. And then looking at short-term supervised programs within that fitness center, and then having walking groups like the Walk with Ease. So there's options for people, you know, what level they can do and what their choices are. So the last one is just talking about, as a health professional, you know, what should you do to look for community engagement? And the biggest thing is do community outreach. Look in your community, because you don't want to have to reinvent the wheel. You don't want to compete against other programs. And, you know, what you do is look for gaps, and then you fill in those gaps of what's not already out there and available. So look what's out there to be able to refer people to, and how can you support the programs that are already in existence, because that's where people need to be fed to. If they're good programs, and you need to keep them going and support those. That's all I got.